I think that if the question is, how do we decide as to which out of the three buckets to use, right? Oral therapy, immunotherapy, cytotoxic, or radiopharmaceuticals in no particular order, I think you find different pockets of practice in North America. I would argue that if this patient was seen in a urology-driven practice and was not seen by a medical oncologist, this patient could, in fact, be actually started on sipuleucel T and then sequenced down the road to an oral agent, right? So I think that it's fair to say that although the challenge of using sipuleucel T in men with metastatic castration-resistant disease is the lack of PSA reduction for most patients or serologic response, the lack of objective disease measurements, meaning that we don't know if CYP-T can actually really impact. I mean, actually, we do know that CYP-T, one shouldn't expect to see radiographic improvement when you use sipuleucel T in the context of that patient population. But at the end of the day, the primary outcome of that data was survival benefit. So I would not be opposed to use sipuleucel T for someone, in that castration-resistant setting. I think the concern for me personally about using CYP-T for this particular patient is twofold. Number one, his Gleason, his high-grade disease. Number two, his time from initiation of ADT until the time when he developed castration-resistant disease, to me, is a bit too short. So that actually almost less than 9 months when the patient actually started developing serologic progression and ultimately develop objective progression. So I am not sure that this perhaps, in my opinion, would actually be the right or the ideal patient in my personal practice to start sipuleucel T right out of the bat. I think that I would probably use sipuleucel T with someone who has a bit more of an indolent disease nature, if you will. I think that brings me to the question of prognosis. How do I know how patients will do when they develop castration-resistant disease? Well, it is fair to say that the contemporary data that we have right now in the United States and throughout the European system as well, universal, I should say, is very clear. We now have very compelling and contemporary data that really allow us to actually educate patients as to the median survival when they walk in the office with metastatic disease. We have plenty of data with Stampede, Charted. We have the data with Titan, the Ensummit, clear data with Latitude that clearly demonstrate that if you walk in the office with metastatic disease and you receive ADT alone, androgen suppression therapy, which is obsolete for those patients, in my opinion, today in 2020, the median survival for those patients taken and live is around 44 months. And if you start segregating patients by volume, if you will, high or low volume, those numbers obviously tend to also to be a bit different, high volume, more aggressive, low volume, less aggressive, and therefore survival tends to be longer. But if you look at the median outcome for most patients in the castration-resistant space, it really depends on the presence or absence of metastatic disease, one, two, and the presence or absence of symptomatic disease. We have very, quite actually neat statistical tools that can be utilized for patients or can be used for patients in this context. We have the Halabi nomogram, we have, the Omelet's nomogram, the Sloan-Kettering nomograms that clearly actually use patients' features to make that sort of decision as to how you can counsel a patient for prognosis. Also use laboratory features such as albumin, hemoglobin, Gleason, and so on to give you a sense as to how people will do over time. The truth of the matter, sadly, is that men who develop metastatic castration-resistant prostate cancer with the best data that we have a median survival between 3 to 5 years. And I think we are pushing that envelope a bit more these days, obviously with the advent of so many new agents. But the reality of it is, if you look at the existing data with Prevail, with Cougar 302, Dosia and Kabasi, in my opinion, are very obsolete today, but there is compelling data right now, and some contemporary for that matter, really demonstrate that most patients, when they develop castration-resistant disease, especially if it's symptomatic and objective in nature, will have a median survival between 3 to 5 years. So you do want to make the best of your time during that sort of short period of time, and that's why understand the right patient phenotype, understand the right and the most appropriate treatment option sequence for your patient is so important. Sadly, the data that we have thus far has never sequenced patients in that context, with the exception of 2 recent contemporary trials, one in the European region, and perhaps actually the data with PARP inhibitors, then clearly demonstrated that in a metastatic castration-resistant prostate cancer space, the sequence from an oral agent number 1 to an oral agent number 2 is not really ideal. So if you think and go back to this particular patient, if you start with an oral agent such as enzalutamide or abiraterone acetate for that matter, most of us, at least in my practice with existing data, I would not sequence the patient back to an oral agent, which means, simplistically speaking, that if you receive ENSA, you progress, I would not put you on ABI or vice versa. So I would change mechanistically what I do for you. Now, the bigger question again becomes that if he gets an oral therapy, he progresses, what will be the sequence to follow? And it really depends, at least in my personal opinion, in my clinical practice, as to how symptomatic you are and whether or not you really need rapid control of your disease. In this case, hypothetically, if he had progressive disease on an oral agent and he's developing rapid symptomatic progression, I just don't think you have the time to invest on 6 months of radium-223, although effective in nature, to control pain and rapid symptomatic control. I think chemotherapy would be, in my personal practice, the best option for this patient. Lastly, if you have the opposite, if you have a patient who's progressing on a slow manner, indolent, if you will, then you have the wiggle room to say, well, do I put you on chemotherapy or do I put you on a radium-223 type of approach? It is unfortunate that we have sometimes no head-to-head trials, and oftentimes we are left at the discretion of how we interpret this data and how we practice clinically. The reality of it is that if you were to actually educate or explain to a patient, I'm gonna put you on chemo or I'm gonna put you on radium-223, and I explain to the patient how these agents work and also what is the side effect profile of these agents, anybody will pick, radium-223. You don't have, the degree of nausea. You don't have the significant risk for suppression of your hemoglobin, neutropenia, febrile neutropenia, and for that matter, alopecia, neuropathy, and so on. I'm not saying that you can compare across trials. I'm just simply telling you that if, in fact, you think of that approach, that, in my opinion, is not the appropriate approach. Now, if I have someone in whom I believe I have the time to invest on radium-223, and in fact, if you look at the Alzheimer's data, the patients who the median number of cycles given on Alzheimer's was actually 6 cycles, right? That's 6 months. It's monthly therapy, IV, given every 4 weeks, between radiation oncology or nuclear medicine. It depends on where you practice in the United States. There are different pockets who actually use these agents. I like to believe that it's orchestrated or quarterbacked by a medical oncologist who's the clinician taking care of the patient, who understands when to stop, when to continue, when it's time to scan, or when it's time to actually move on to something else. But if you make that decision and you have a patient in whom you believe you can actually at least give him 4 cycles of radium-223, and you don't need rapid control of his symptomatic progression, then that will be the type of patient that I would probably be in line to actually offer him radium-223 in the sort of the pre-docetaxel space, if you will. Now, it's very important to remind the audience as well that Alzheimer's did not allow patients with visceral metastases, and it certainly did not allow patients with bulky lymphadenopathy, and in that trial was defined as a greater than 3 centimeters for lymph nodes. So when you really think of that, I would argue that if you have someone with visceral progression, which is very uncommon in prostate cancer, I would argue probably less than 20% of patients we see with visceral disease. But if you happen to have someone with visceral disease in the castration-resistant setting, I would not think of radium-223. I would think more of chemotherapy, to be transparent with you, although I would argue that the data with ENSA and ABI could be applicable to those patients, recognizing that one of the 2 trials did not allow patients with visceral disease in those to enroll on the trial.